Now for our final speaker, I'm delighted to welcome Professor Peter Hajek, and you'll probably already have spotted that both Jeremy and Lisa have referenced Peter in their talks. Peter is the head of psychology and director of the Tobacco Dependence Research Unit at the Wolfson Institute here in London. And Peter's work is particularly around health behaviours and around developing and evaluating both behavioural and pharmacological treatments. And it seems very apt to end with getting the most out of current treatments. Thank you, Peter.
Thank you for the introduction. Thank you for inviting me. I was given this particular topic to talk about, getting the most out of current treatments, so I racked my brains and came up with a few tips and advice. I didn't quite realize that my talk is the last. I guess that was the attempt from the organizers to bring the excitement down a little bit and let you go home in the same state you came. Why should we try to get more out of current treatments? Well, we have effective treatments, no doubt about that, but there's a large scope for improvement. The Stop-Smoking Services, the last survey done by Linda Bolt, I'm not sure if she's here, that was quite some years back, and across the services, the one-year quit rates were 15%. The same exercise is going on at the moment, and I think that the figure is lower. That, of course, combines the level 2, level 3 advice and everything else we're doing, and it's miles better than unaided quitting. This, it's probably less than 5% for the dependent smokers who seek services. So we are providing very useful service. We are helping people who wouldn't be able to quit otherwise, but obviously a huge scope for improvement. And as you all know, smokers are not flocking to our services in large numbers. What can we do to make it a bit better? And I'll cover 3 things. Do not provide ineffective treatments, which sounds trivial, but I'll elaborate on it a bit. Keep up to date and use new treatment variations when available, and also research. Now, I won't be elaborating on that much, so I'll tell you now. Nowadays, when there's a project going on which is evaluating some new development, it's usually matching the standard treatment you're providing with something where there is something added to it. So people are randomized not to no treatment, but to good treatment and something which potentially is even better. And if you're part of such research, you're providing what you would normally, but you also have a first bite of a cherry of something exciting and new, which may turn up to be helpful or may not. But you're not selling your clients short. And all these trials require large samples, and very often there's a problem in recruiting enough people. And Andy McHugh and others every now and then issue some calls for collaborators and looking for services which can actually chip in. So next time you'll see it, I would encourage you to respond and join us and be part of these various research programs. Okay, the first point about ineffective treatments. You heard Lisa mention the new NICE guidelines, and we were reviewing stop-smoking interventions in acute and maternity services and also in mental health services for the NICE guidelines. We went over a large number of papers, and in one slide, the conclusion is, now here we're talking about secondary care patients, people who are in the hospital or they may be outpatients, but they have very often smoking-related disease and they carry on smoking. So by definition, they're highly dependent smokers. And brief interventions and even more intensive interventions, but with a follow-up of under 4 weeks, do not help them. You need to see them for over 4 weeks and provide support and combine with medications. And it's such a simple conclusion, strong evidence-based, don't bother with brief treatments for this type of people. And frontline healthcare staff should not meddle in with brief treatments. They should just refer everybody to specialist services who will have dedicated staff, hopefully, who can provide this. And yet, some services still focus on training frontline staff to deliver brief interventions which are not effective, and referral to services from secondary care is miserable across the country. Barney Proctor recently completed a survey of services, and some of you may have been part of that survey, mapping the operation, the level of referrals, the barriers and facilitators, and it's extremely useful. And I wish similar things were done for all parts of the service, those which target youth and those which target pregnant women. That's actually been done, but quite some time ago, and so on. And I want to put in some useful bits in this talk. So this is how you can get in touch with Barney Proctor if you're working in secondary care and want to be part of the network which shares various research findings and helps this with type of data gathering. So we need to appreciate that the profile of smokers in the UK has changed. When smoking rates were high, there will be many smokers who benefit just from brief advice or calling a quit line, getting a bunch of leaflets, and it's not true anymore. When this, easy touch smokers are gone, we now have smokers with increasingly demanding treatment needed. They may have mental health problems, comorbidities. They've already been treated in the past and didn't help them. And the new priorities are intensive treatments and harm reduction, because you will be increasingly meeting people who are not going to stop smoking. You can try to help them until you brew in face, and at follow-up they are back to smoking. But you could still do something to help them not to die as a result of their smoking. So we should refer smokers who need help for specialist interventions, not for brief interventions. I think we need to rethink the level of what's called level 2 advice. Talking about Linda Bolt research, you probably all know about her research on pharmacist intervention in Scotland, where the one-year follow-up rates were 2.8%, which is certainly not higher than you would get with no treatment, because they just don't have time. They can't set up number of sessions and follow people up for a number of weeks. I think the core focus of stop smoking services should be intensive treatment provided by people who are trained to do that. All right, now moving on to medications. Can we do better with medications we have? What's on the next slide? Right. There's a little bit of a grumble here. A remarkably conservative situation we've got. NRT were brought onto the market in early 1980s. They were developed in 1970s. For over 30 years, there have been no improvement in them. When Mike Russell started with nicotine chewing gum, nicotine nasal spray, he wrote a paper where he predicted that early on in the 21st century, smoking will be gone because pharmaceutical industry will develop better nicotine replacement treatments which will just replace smoking. People will still use nicotine, but they won't be killing themselves, and the problem will be solved. And he was wrong. Pharmaceutical industry did not develop new NRTs. They just carry on using the same formula. Why? Because of the cares of medicinal licensing. I know Jeremy sitting there, and he won't like me saying that. And I believe that medicinal licensing, it's a very, very useful thing, and it can be much lighter touch, but normally innovation doesn't go with medicinal licensing. If you want to develop your product, if you want to tweak it, it's just prohibitive costs. And we'll be talking later on a little bit about e-cigarettes, and your average e-cigarette manufacturer brings about 5 new tweaks and products per year on the market. It would cost them millions of pounds to get medicine licensing for each of these little improvements. And that's the reason why NRT did not develop at all. And it was snus and e-cigarettes now which are bringing the next generation of nicotine replacement treatments. And varenicline, in a way, similar. It was launched 7 years ago, and there are, of course, possibilities of higher doses and various innovation ways of using it, but it's also not happening with any great speed. So let's see what we actually can do with the licensing we currently have. And in this country, to the credit of our medicinal licensing authority, they're much more liberal than, for instance, in the United States. They're really the good guys. We have much more open and rational regulation of nicotine in this country, and we can use NRT over extended period of time. We can do preloading, we can do combinations. So which of these we should actually go for? So the first idea, using NRT for longer. Now, I was thinking of some kind of pictorial representation of hooray, it works. We are not sure, and disappointment. So see if you can figure which one this is. Okay, so that's a disappointed person because using NRT for longer doesn't seem to do much. Cochrane reviewed studies which extended NRT use up to about 12 weeks. From 8 weeks, there was no effect. There was a newish study which argued, what if we forget just a week or two, let's give it to people for 6 months. And people either got placebo or NRT for 6 months after the initial 2 months when everybody got the real thing, and there was no effect. So that one bites the dust. What about using NRT before you quit? You will all typically use NRT from the quit date on. Why would you use it before you quit? Because it may spoil the enjoyment of smoking. People will already smoke less, and then quitting may be easier if what you're giving up is not very rewarding anyway. So there's a good rationale for it, and we are not sure if it works or not. This is what we know about it. There was a first review, a number of papers have been done on this, and the first review had very enthusiastic conclusion that it's brilliant, it has got strong effect. Then a few more studies came up, and then the second review was published by the Birmingham group, and there was actually no effect now. And NIHR currently funds a very large study of this, when people are getting pre-treatment for 4 weeks with patches before they quit or not. And when the study is over, we will know if it works or not. This is coordinated by Paul Aveyard, who's now at Oxford, and my group is involved, and people in Bristol and Nottingham as well. So it's a large study, struggling with recruitment at the moment across all these sites, and when it's done, we will know whether it's useful or not. Now, a lot of people do this anyway. Our service, for instance, is using this with mental health service users, where abrupt quitting seems to be very difficult, and quit rates are low. And so the idea is that people are kept on NRT, and they're cutting down. NRT may be even increased prior to quit date. If you do this, you will, the question you will face is, should I ask people to cut down while they're doing this? And I would advise against it. I don't have strong data for it. This is just coming from first principles. If the aim is to make cigarettes less rewarding, you don't want people to be cutting down. You want them to smoke and get unrewarding cigarettes as much as possible. So you ask people to smoke ad lib. And some of them will spontaneously cut down, which is a good thing. But if you ask them to smoke just 5 a day or whatever, they will be running into withdrawal, and they will be enjoying the remaining cigarettes, and you will actually disable the effect you're trying to achieve. And by the way, that's one of the unanswered questions about previous research, which was mostly done in America, and people were mostly asked to cut down during that preloading period, which may have actually acted to disable the effect you're trying to achieve. The next one, should we tailor NRT dose to response? I explain what I mean. You put somebody on NRT, preferably before they're quitting, and they come back a few days later, and you have them to blow into the carbon monoxide, ask them how much they smoke, and if they smoke didn't change at all, you put another patch on them, and they go away again. And you increase nicotine dose until they can't smoke, or they can't smoke as much as they used to because they will be sick. And now you turn them into NRT reactors. You are spoiling the enjoyment of smoking. Would that have an effect? I think this is a productive idea. Somebody here asked a question about the safety of using e-cigarette and NRT. I think we now know that these things are safe. There's a built-in safety valve. People get sick. If you're overdosing on nicotine long before you can poison yourself or do any damage, you just experience nausea, and you stop smoking or spit out the piece of gum which was too much nicotine for you, and no the health damage can come about. So these things are safe. So does it work or not? We don't know. There is a reason to believe that it may work. Anecdotally, there are reports about it, but the studies are needed to do that. We're currently preparing a grant application for this, and may come to you guys to help with implementing the study if it ever gets funded. The next bit, e-cigarettes. Now, I was asked to talk about things which are already there. I'm not talking about any new treatments on the horizon, just what we already have. Well, we already have e-cigarettes. People can buy them. They are out there. What should we do about those as part of our treatment or not part of our treatment? And this is something we don't know, but there's a big, big hope for actually saying hooray. It's the most promising development by far in tobacco control we ever had. It needs time to evolve so that it actually kills cigarettes. This is one chance we have for what's called the end game. In 50 years' time, or maybe even 10 years' time, there may not be a single smoker around because everybody will be using e-cigarettes the way nobody now uses ski bindings, which are dangerous. Everybody uses ski bindings, which are safe. But they need to develop a bit better. They are not yet, for a smoker, they don't get as much from it as they get from smoking cigarettes. The recent UK ruling to have them medicinally licensed will stop development. We already discussed how innovation doesn't quite tally with medicine licensing, but fortunately, this will only happen in 2016. Actually, the European ruling now puts it to 2017. So e-cigarettes have few more years to develop. They're developing very, very fast. This is a very lively field. And so I would now hope that by then, the product will be good enough. But once it's medicine licensed, it will be fossilized. It will stay in the form it will be then, which I don't think will be good for public health. So here I differ from the majority opinion on this. But they're already, at least, I would say, as good as nicotine replacement we have. But we don't have randomized controlled trials yet. There are some in the pipeline, not as many as you would wish. It's already used in various priority groups. For instance, I know about forensic psychiatric unit where patients automatically receive e-cigarettes if they're smokers and they're being hospitalized there. They can't go out and smoke, but they're given something which is satisfying, and I think it's a great thing to do. We need some kind of guidance for the service. What are you supposed to do? How you answer these questions? We are working on something like that. I'll give you some ideas about it here. Now, I'm telling you they're as good as NRT. How do I know? Well, this is effect of nicotine delivery, craving relief. This is very good. If you look at what type of nicotine levels people can achieve, you need to do it with experienced users who use their own electronic cigarettes, and you see that they get levels as good as you get with smoking. Now, the important thing about e-cigarettes is that there's millions of brands, and it's a good thing. Different smokers need different things. They differ in things such as not just nicotine delivery, but things like taste, draw resistance, even how soft or hard is the bit you put in your mouth. And people need to find the one they like, and then they will use that. If you narrow it down to just one product which everybody has to use, you would actually get rid of something which is really good. And we already have some evidence of these things being helpful, even to smokers who don't want to quit. This was a small study, but the results are very encouraging. At 6 months, they didn't want to quit, but a quarter of them quit using e-cigarettes instead now, and a lot of them substantially reduced their smoke intake. So the potential is clearly there. This is a very recent quote from a very respectable and fairly conservative smoking cessation researcher and dean of public health studies in America, who's saying, if I had a brother or a child or a friend who smoked, I would try to get them thinking about e-cigarettes. And I wonder how many of you advised your smoking friends to try e-cigarettes. I certainly do. I think this is the best advice I can give to somebody who comes to me and they can't stop smoking. What should they do? And I would say, go and try a few of these. Don't just try one, try 3 or 4. Start with disposable ones because they don't cost much, and you see if that's the type which actually does something for you. Once you find a good one, then you buy the charger because it's a bit of investment and it becomes cheaper after that. So what do we tell patients attending our clinics and asking about electronic cigarettes? If they say, do you recommend them for quitting? At this stage, before we have proper evidence, I would say, for now we want you to use NRT or Champix. That's what we provide, that's what we work with. But if you want to try electronic cigarettes on top of it, that would be fine with me. And they may help. They may provide some extra help. And if they are really keen on that, I would give them the advice I would give to a friend. And if they have a go, I want to hear back because I'm gathering data on which brands do what and what to recommend next time. And if they ask, are they safe? Well, there's no question they are orders of magnitude safer than cigarettes. More research is needed to see whether they are completely safe, but you're a smoker, I wouldn't worry about safety at all. All right, now let's have a look at Champix. My light is still green, so I can carry on. Do we have any developments in using Champix? Well, Champix preloading. How about giving people Champix before they're quit, longer than just a week or two, which is the norm? The logic is the same. And here we've got hooray, right? This is Australia for some reason. I couldn't find any other hooray slides, but it's good enough. So, as you know, Champix acts in two ways. It alleviates withdrawal discomfort, and it reduces reward if you do smoke. And current treatments does not use the second mechanism at all, because you're only using it for a week or two before quitting. Start with low dose, so you don't really expose people to non-rewarding cigarettes, which is the key. Now, if you do preloading, you do that, and for people who react to varenicline, which is not all, only a proportion of your smokers are what we call Champix reactors, they will smoke less, they will not enjoy their smoking much, and after quitting, they will benefit. And we published the first paper on it a couple of years ago, and we had highly positive results. Prior to quitting, you can see that coating, and we were very careful to tell people, smoke as usual, don't try to cut down. And you can see they're inhaling less, they're smoking less, they're not enjoying their cigarettes. We asked specifically about enjoyment as well. And then after the quit date, the abstinence is much higher in those who preloaded. And those who reacted during preloading are the ones who benefit, and they have unbelievably high quit rates, those reactors, after quitting. Since then, 2 other studies confirmed this effect on reduction and loss of enjoyment prior to quitting, and I think we just should start using it. Product labeling allows it. It tells you that it can be used for up to 5 weeks before quit date. You don't have to stick to 1 to 2 weeks. And if you're worried about costs, I can see how commissioners among you are shrinking back into their chairs thinking what's gonna cost us. It doesn't have to. You can take off a few weeks from the end of the 3-month course. So if these people benefit and they quit successfully, you don't have to keep them. You can keep them on Champix for 3 months, but you don't have to. If they didn't smoke at all, probably if they're totally abstinent for a couple of months, they don't need the medication anymore, and you can shorten it there. So there is at least one concrete advice for you. How about Champix plus NRT? This is another scratching. Oh no, that's a disappointment. This is a disappointment one. And I think Katie Myers, who was involved in our trial, reported about it, so some of you may already have the details of it. Combination doesn't seem to work, disappointingly. So there was no effect on quit rate. There was a hint of an effect on people who do not react to Champix at all. They may benefit from NRT, but the study wasn't powered for subsample analysis, and so this didn't come up significant and need another look into it closer. But overall, combining the 2 medications, the commissioners will be relieved, is not working. Should we tailor Champix dose to response, the way I was describing before about NRT? Should you keep increasing the dose of Champix prior to quitting until people say, I can't smoke, I'm not enjoying it, and then make them from non-reactors to reactors and then getting better quit rate? There's a scratching of head. We did that study, we got funding for it, and we looked at it, And we've completed it, but we don't yet have results. We will be reporting it soon, and it will also be covered on the regular annual update. And actually, I'm using the opportunity to plug the annual update. You probably, most of you, I can recognize that you come to these updates, but if you don't, once a year, we have this day when we update people on what's new in research, treatment, legislation. There's also troubleshooting and clinical supervision sessions and sessions for special groups who deal with young smokers, pregnant smokers, and so on. And if you're not on this mailing list and don't come to these and you're interested, this is the address to email to get onto it. So in summary, and I still have got the green light, so I don't have to rattle on very quickly. 3 things are in red there. Use the best treatments, not the second best, if you want to move up that 15% quit rate a bit higher. And we have evidence from the services, which I actually didn't talk about before, that some treatments have much higher success rates than others. And the specialist treatments groups, which of course a lot of people can't run, but they have the highest quit rates. And then less effort, less intensive treatments, lower outcomes. And so focusing on best treatments, not the second best. For old NRT, we've got a couple of things which may hold promise, but we have to wait until we get the results. For new NRT, which is currently e-cigarettes, I would already be very open to allowing people to use it as a supplement, and I think we're not far from actually actively recommending it to be used as supplements to whatever other treatment you're providing. For Champix, I would say preloading may increase your quit rate a bit, and dosing to response, we have to wait what the results are going to say. And so I think I'll finish there. I hope you like my rating scale of hopeless to hopeful.